Our moderators for the session are Dr. Jasmine Vora, Dr. Mandeep Tellara, Dr. Utsav Unadkat, and we have chairperson, we have Dr. Tarun Dave, Dr. Surinder Devra, and Dr. Jael Shah. I request moderators and chairpersons to introduce our speakers and then introduce the case, show the PPTs for the same, and then go ahead and have the talks.
Okay, very good afternoon. Sir, am I audible?
Yes, you are. Please, Dr. Surendra, go ahead.
So welcome all of you for the CardioCon 2022. So shifting our gears from carotid to again coronary, back to coronaries, we have two wonderful speakers with us. Dr. Anand Shukla, I think we all know him. He's a senior interventional cardiologist at Ahmedabad. He is a professor at UN Mehta Hospital also. And on the other side, we have Dr. Sanjeev Kumar Sidhana. Can we have that slide, please? Dr. Sanjeev Sidhana. Yes. So, Dr. Sidhana, he did his MBBS and MD from BHU, Varanasi, and from RML hospitals. He did his cardiology training from RML hospital and did DM from SMS Jaipur. He is presently senior interventional cardiologist and associate director at EACC Jaipur. So this on this hot debate, the case, I will just brief about the case. So yeah, the case is 68 years old male. He is having a new onset of atypical angina with an inconclusive at 5 minutes with fatigue. Angiography, always, which we always see, it's around 60 to 70% of the stenosis on QCA at LED ostium, with 65% at the large diagonal artery. Now, such type of anatomy, they always have a dilemma. How should we proceed on? What should we do first? Should we go for imaging? Should we go for our eyeball assessment? How should we go about this? So I think I will request Dr. Anand Shukla to start his talk about the imaging, in a role of imaging in such type of patient. Dr. Anand Shukla.
Yeah, yes, I'm try to share my screen. Can you see my slide? Can you see my slide? Okay.
Yes.
So thank you, Kamal, and the moderator to introduce me. So today's topic already that angiography has been solved. So I will going into detail so we can have good discussion and debate. So myself in the what is image seeing is the believing. How can, if you see the pretest probability, the evidence are less with me, as just like the pretest match result of this Indian West Indies match. So as we know that the moderate lesion, still the physiology has upper role as evidence wise. So I will divide my presentation into understanding of the given scenario and in what is the intermediate lesion, why we require the debate on the intermediate lesion, current accommodation, any role of imaging modalities, and what are the evidence for the intermediate imaging modalities. So as per this case fall in the not tested or tested performed with the intermediate result may be considered as per the appropriateness criteria for the revascularization. So we define the just briefly intermediate lesion. The definition given in 97 by the cold and liposcum from animal model. After that, it has never been testified in any trial. The 50% threshold has been consecuted as a part of intermediate lesion. QCA versus experience angiography, there is always 10 to 15% observation variability. Till debate is today going on. FFR still a gold evidence-based more support than the imaging. But 20% of severe LED ostial lesion may turn out to be FFR negative, and 20% of FFR negative lesion carry the vulnerability. So we can focus on this part. So why intermediate stenosis require the analysis before going for? We can put the stent DES with the good success rate. We are good confidence. Why debate? Because by deploying the stent, we replace the atherosclerosis disease by the stent disease. So stenting itself is a iatrogenic disease. FFR negative lesions carries the event rate 1% per year, while if we take the conservative approach, even modern stent carries the complication rate by 2 to 3.5% per year. So preferable to have objective evidence or convincing subjective objective evidence of ischemia before going for the revasculation. So it is a debate like being human or being the cardiologist, whether patient will benefit or not, then will I take the decision. So current accommodation for the FFR, all we know that is much more evidence in favor of the physiology. Physiology can be done instantly with the now more and more widely acceptable. But adenosine induced vasodilatation is not natural physiology. What we patient do by exercise, the neurohormonal and vasodilatation is totally different than the. It is a like vivo versus vitro model. Bifurcation lesion FFR measure prone to error. FFR and 2 lesion cannot be assessed because there will be the crosstalk also. And what about it? Each never bother about flow across the lesion. Simply regions rely on pressure difference. Just there is a no severity criteria of coarctation by difference of upper limb, lower limb BP measurement. So how accurately we can imply the FFR criteria to the final decision? It is not. We have to think of over and above FFR in certain, not all scenarios. So if we ignore the morphology of lesion, we know that eccentric soft lesion with the good distal FFR is a light coronary explosion. Yeah, these are the theoretical limitation of the FFR. Enumerating. If I am seeing the FFR in the other angle, that's why I am mentioning out. It may be overestimate, underestimate vasospasm, tortuosity, elevator right pressure or the right side heart failure. If during the FFR measurement, your mean systolic pressure less than 60, then underestimate the FFR. Hypertension, there is left ventricle hypertrophy, microcircular dysfunction, aortic stenosis. So these are the condition where we can, because we rely on the simple digit, that is 0.8. And if that 0.8 is going to influence by so many conditions, we should be concerned, care about that digital 0.79 versus 0.81 value. So FFR is less than point, definitely be revascular intermediate lesion. But in the distal proximal LAD, ostial LAD, and the bifurcation, we may require, or in the underlying condition, if it's unstable. In this case, definitely we are discussing the stable condition, stable angina. I never come out of any literature due to inherent nature of interventional cardiology to do something for the societal lesion. So I could not find any trial for FFR positive and revascular differ on the imaging basis. That is a cardiology bias data, because we want to do something, we want to stand. That's why I could not find any literature. So if FFR is more than 0.8, everybody agreed that nobody touched the lesion. But there are some data recently by the Prospect and Forza study. So we can have. So intermittent low image, that is my main talk. That is a 2 trial that I could find some evidence for this. This is a Forza trial is done by the Francisco Barzotta. That is a aim of the study to compare the OCT guidance and fractional power guidance in patient with angiography intermediate coronary lesion angiography in a single center prospective 1-to-1 study. The conclusion is that trial in the patient with angiography intermediate coronary lesion, OCT guidance is associated with the lower occurrence of composite major adverse cardiovascular event or significant angina. FFR guidance associated with the more medical management and lower cost. The OCT has more stenting, but outcome is not worse than the FFR guidance. Similarly, there is a percutaneous coronary intervention of vulnerable coronary atherosclerosis by the Greg Stone and Ziad Ali. Similarly, occurs mild intermediate lesion. The PCI of angiographically mild lesion with a large plaque burden was safe, substantially enlarged the follow-up minimal lumen area, and was associated with a favorable long-term clinical outcome, warranting to perform the adequate power study. So these are the 2 studies have shown that even though the FFR negative, one can take the decision on the basis of the image morphology. This is a proven EPSOP trial, the outcome, that is a blue line is a EPSOP BBS plus guideline directed medical therapy versus guideline medical therapy alone, that is a red bar. So the less mass in the EPSOP plus guideline directed medical therapy. Another trial is the optical OCT guided complete decision making, analysis as well as indication. So the new terminology has been introduced, optical flow ratio. Just now computation, they have derived the mathematics of computer optical flow ratio. We can have assess physiological as well as anatomical. So these are the parameter may in future help to diagnose, because physiological we have assessed by the FFR, but if we combine the anatomy and physiology, that will be the better for the long-term result. So OCT can help to identify the morphology and physiology, therapeutic and therapeutic on the whole circle we can justify. Now these are the certain OCT criteria and how they compare with the FFR cutoff value of 0.8. That is a potential sensitivity specificity ranging from different. There is no clear-cut guideline that these are the OCT values, this will have less than FFR. But these are the trial. You can compare the OCT data with the FFR. Similarly, there is IVUS data also. The assessment, IVUS assessment to angiography intermediate lesion. That is a MLA, that is a 4 millimeter, plaque burden more than 70, luminance stenosis more than 70, and the arch more than 90%. That will identify to helpful to revascularization in few trials. So these are the trial for the IVUS and FFR comparison, LMCA, non-LMCA, and these all trial their baseline cutoff will be different area with the sensitivity, specificity, positive predictive, negative predict value that compare with the FFR trial. If you are angiography, if you are using the IVUS in the proximal LAD or the proximal circumflex dominant, if MLA more less than 6, then FFR or non-invasive trace is available. If it is not, then area stenosis more than 60 to 70%, plaque burden more than 80%, lesion length more than 20%, one can take the decision for the revascularization. If MLA more than 4, then defer the revascularization. These are the angiographic IVUS guidance for the intermediate lesion approach. So why the data is lacking for the stenting the vulnerable but fractionally flow negative result? Because there are 3 trials, one prospect absorb trial result I have discussed, that is a Greg Stone and the Gia Dallari trial. Another 2 trial on the way, there is a prevent and a practice, the result expected in 2022, where the FFR negative and the image guided trial. So why there is evidence lacking? Because it required the 23,000 intermediate lesion screening. Among that, 3,000 patients required to study for the randomization. The large number of, so 23,000 patients screening and approximately 4,000 patients to be enrolled for the intermediate lesion with FFR image to prove the image is additional to FFR. That nowadays is maybe the evidence based is not possible. That's why we are lacking the good clinical large data. And approximately 60 to 20% of FFR negative lesion were having thin cap fibrous atheroma. That is Zimmerman recently in JACC intervention they have published. So what are the vulnerable plaque? Plaque burden more than 70, plaque area more than 70, MLA in proximal vessels, non-left man, less than 4 millimeter, fibrous cap thickness is less 150 in the prospectile, but ideally 67 is taken for the thin cap fibrous atheroma. So these are the different criteria for the vulnerable. If you find this vulnerable, even the lesion are FFR negative, if the lesion is situated proximal LAD in circumflex, then we have to think of the revascularization taking the under overall holistic approach. So the future of OCT and IVUS or any imaging assessment may lie in the coupling with the computational flow dynamic, that was CFR or any computational flow dynamic simulation of coronary flow and the pressure. Simultaneous anatomy functional assess may be the future of the imaging and the physiology to define the approach for the intermediate lesion. These are the 3D IVUS and OCT accuracy against FFR point accuracy, 90% specificity, and the positive predictive negative predictive value. Because we believe that till date, as per the evidence, FFR is the gold standard. So although the FFR in imaging are eloquent proponent for the either technique, both procedures are valuable in cardiac catheterization laboratory and provide critical information that supplement the foundation of high quality angiography. If PTS is indicated, then we require the shift from anatomical revascularization to physiological revascularization. FFR is more applicable, and IVUS has role in the proximal LAD in the left main. If you want the PCI, these are the previous. If you want to do the PCI by anyhow, then do the IVUS. If you do not want to PCI, then do the FFR. And beware so long as you leave the judging the men by their outward appearance. So we have to approach the patient as a whole rather than the lesion, because we are not treating the lesion, we are not treating the isolated symptom, because we have to improve the ischemia or ischemic symptom as objective subjectively. Thank you.
Thank you, Dr. Anand Shukla. I think we will continue this discussion on the other side, the role of FFR. I will request Dr. Sanjeev Sidana to please start the discussion.
Thank you, Dr. Dr. Deora, sorry, and Dr. Anand. I think Dr. Anand has made my work very easy, and we'll not going to take this as more of debate, because unfortunately there is not much of randomized data is not available on this subject, and both these tests, they are so different that it is very difficult to compare them and to make a debate, because one is definitely anatomical test, one is physiological test, so both are very different. And while searching for the data, only one large randomized trial I could come across, that was a flavor trial which is being conducted in the China and the Korea, but unfortunately they have completed the randomization and the results are yet to be out, so there's not as much of the randomized data is not available. So I'll continue with my presentation quickly, and then we can go on with the discussion part. And once we have done an anatomical test, that is angiography, then definitely the next logical step should be a physiological assessment of the lesion, because ultimately the purpose of our treatment is to relieve the ischemia at the tissue level. And these are some of the unique features which are very unique to FFR, and it is very easy to perform. And normal value is 1 for every patient and for one every artery. Like it is not like IVUS that all the arteries, they have different areas, and even the areas vary from the ethnicity to ethnicity. Like criteria for cutoff for Europeans are different from the Asians, and FFR is not influenced by the changing hemodynamic condition like heart rate, blood pressure, and contractility. FFR specifically relates to influence of epicardial stenosis through myocardial perfusion area and blood flow. So that is very important, and it takes into account the collateral flow also, and it has got a very circumscript single threshold value, that is 0.8, that is taken to indicate the ischemia. And FFR is very easy to measure, and with the success rate of 99%, it is extremely reproducible. So we know that angiography may always over or underestimate the lesion severity, and even if the patient we consider in which diameter stenosis is from 50 to 70%, 65% of the patient, they may have a FFR value of more than 0.8. So that actually emphasizes that all the lesions in the intermediate severity should be assessed with the FFR, and even the lesion stenosis of 71 to 90%, 20% of the patient, they may have a FFR value of more than 0.8. And FFR is highly, it is very reproducible investigation. And in this, we have compared that first FFR measured with the second FFR, and they are highly reproducible. And like I have said, that the cutoff criteria for cutoff diameter and area for left main, non-left main arteries, that is different, and it varies from ethnicity to ethnicity also. And but in case of FFR, it is value is 1 for all the arteries and for all the patients, irrespective of the ethnicity and the size of the patient. And this is how we actually conceptualize how to measure the physiological effect of FFR. The aortic pressure is directly transmitted into the coronary tree, and we can consider that this pressure is equal to the aortic pressure, and if there is stenosis, then definitely the distal pressure will be low. And once we induce the hyperemia, we can actually accentuate the effect of this stenosis, and then we can measure that whether FFR value is less than 0.8 or not. So this is the physiology again. The FFR is the flow of maximum flow in the stenosed artery to the maximum flow in the normal artery. So that can be calculated with the PD minus PV upon the PA minus PV divided by the resistance. So we can simplify this by removing this venous pressure, because that is close to zero, and by resistance by inducing hyperemia, and these two are very low, it's close to zero, and we can remove them, and we can easily calculate the FFR by just taking the ratio of PD by PA. And it is very easy to perform the FFR, and just we need to take a FFR wire, and we need to actually equalize it first to the atmosphere, and then we need to equalize after taking it out of guide, and once we equalize, and then we this wire is actually advanced distal to the lesion, and maximum hyperemia is induced with the most commonly with the adenosine, that is intravenous adenosine, and it is very easy to calculate the ratio. And if it is less than 0.8, then we need to treat the lesion, and if it is more than 0.8, then it is we can leave the lesion. And it is very easy to interpret the result of FFR when we compare it with the IVUS. It doesn't require much of technicality, and we'll get the result in a value, and we can actually decide whether to treat the lesion or not. And it is equal to 1 in all the arteries, and will be less than 1. It will take into consideration the perfusion area also. So for the same amount of stenosis, if the artery is supplying large area, then FFR may be significant, and if it is supplying the small area, FFR might not be significant. And again, take into consider scar tissue, which will not be considered in the case of IVUS, and because we are doing physiological assessment, so because scar tissue will not require much of the blood flow, so we conduct, if artery is supplying scar tissue, then FFR might be normal, and if it is supplying normal tissue, FFR might be abnormal. And the other part is that it will take into consideration collateral flow also. So if the area is receiving collateral flow, FFR might not be significant, and we do not treat this lesion. And this part is again missed by the IVUS. And although it has been said that IVUS actually lead to optimization of stent, and it will improve the outcome, but FFR also can be used to improve the outcome. Like this is data which showing that FFR after stent deployment is, if it is more than 0.96, then the TPR at 6 months is only 4.9, while it increases with the increase in the FFR value, decrease in the FFR value. So FFR data is very much validated, and it has been validated against many non-invasive tests which actually used to produce the reversible ischemia, that is exercise test, thallium scan, and stress echo. And 0.8 value 0.8 has been correlated to all these non-invasive tests. And this is highly sensitive and specific. And if FFR is more than 0.75, the ischemia is very unlikely, with the sensitivity of 88%. And FFR is less than 0.75, it is very specific with the specificity of 100%. And we have a lot of clinical data in the favor of FFR. And these are the 3 large trials which have been conducted, that is DEFER, FAME1, and FAME2. DEFER trial actually involved 325 patients with the patient who has got FFR of less than 0.75, they underwent PCI, and patient with the FFR of more than 0.75, they were again randomized to PCI and medical treatment. And this shows that revascularization of stenosis with FFR of more than 0.75 is not inferior to PCI. And again, in the FAME trial, the 1,000 patients were taken, and in one group, the PCI to all the stenosis of more than 50% was done, and other group was randomized to FFR, and the PCI was done only if FFR was less than 0.8, and this trial shows that revascularization of only the stenosis with the FFR of 0.8 is not inferior to revascularization of all the stenosis. FAME2 trial again showed very strong evidence, and it was stopped prematurely because it showed that if we do not do PCI in subgroup which has got FFR of less than 0.8, they are going to have more events. And again, showing the data from the FAME trial, and FAME2 trial again says that the PCI with DES provides sustained benefit in the patient who has got FFR of less than 0.8, and reducing the incidence of need for urgent revascularization, rate of spontaneous myocardial infarction, symptomatic relief, and without late catch-up phenomenon. And not only it actually improves the outcome, it also reduces the cost also, because in many of our centers also the cost of PCI is it costs around 1.5 lakhs, and the FFR can be done only with the 30 or 40,000 rupees. And guidelines also recommend FFR as class 1 in recommendation by the European guidelines and class 2A by the American guidelines. So to conclude, I would say that FFR should be choice of modality for assessment of borderline lesion, and there is a lot of data to support that FFR guided PCI reduces the cost of therapy and increases the health outcome of the patient. And FFR takes consideration the perfusion area and collateral, thus guiding on the requirement of DS implantation. And ESC guidelines, they classify FFR as a class 1 indication, and while imaging has been given class 2 indication, and FFR is much better third eye for the borderline lesion when it is compared to imaging. So with this, I'll end my presentation, and we can continue with the debate.
I think we agree, we all will agree that there cannot be debate between the IVUS or FFR and IFR. One is physiological, another is anatomical assessment of coronary lesions. But I will request Dr. Shukla and Dr. Sidana, what exactly to do in this patient who is having an ostial LAD of around borderline 60-70% of lesion.
In this, my personal feeling is that the FFR in this index case, suppose you take from the diagonal or do it from the LAD.
Can FFR we have that angio, please? Angio pic, please.
So that was an anecdotal example. The lesion that we are showing is actually a LAD diagonal bifurcation. But then the case that we have given here is an ostial. So we need not go by that. I think the case history is more important that we are looking at. So what we need to be discussing is a ostial LAD. How often do we end up not doing anything? And I think Dr. Anand Ahuja has also asked a very pertinent question. What if you have imaging positive FFR negative, and what if you have imaging negative FFR positive? So, if you either of the scenarios, where would you end up?
So first I will start with the imaging part in the ostial. The ostial LAD is not the isolated disease. Hardly 15 to 20% with isolated ostial disease. Some plaque distribution in the either distal left main or the adjacent circumflex. So this ostial location is such a time bomb. If we leave the vulnerable morphology. So my opinion would be that if you decision take revascularization FFR negative, but before giving the clear green signal, no need to only medical, then if possible, then the anatomical assessment would be the advisable, as the ostial isolated lesion also spill over to the distal left main and also. Dr. Sadana.
Yeah, definitely the important point in this particular case is that he has got a new onset of symptoms. So that this particular patient might have a unstable plaque, and we might need to do imaging in this patient also. And if we demonstrate that this patient doesn't have any vulnerable plaque, then FFR can be done, and or we might do FFR first, and then if FFR is so one of these modality can be used first, and if we use both the modality, then definitely we can plan the treatment better.
Or nuclear trace test and FFR, because functional assessment, any trace test, suppose TMT, he could not do the TMT more than 5, or TMT inconclusive. Then we can think of the nuclear trace test, exercise test or a pharmacological nuclear trace test to see the indicible ischemia in LAD territory plus FFR before giving the say that you are the safe for the medical management or the combination.
In the same situation when we have performed the angiogram, then definitely it is not possible for the patient to do a second procedure. So we have to decide in the same test. So then definitely FFR, because the patient doesn't have a typical symptoms. Patient has got
yes,
atypical
yes.
symptoms, so FFR can be first line of
And
investigation.
then no hypertension, no other risk factor except the age. So other
Yeah.
panelists, Dr. Tarun Dave, and
Yeah,
what is
Anand,
your estimation?
my suggestion is that suppose in this case you have done an
Yes,
imaging and
yes,
FFR is you see 0.8 or 0.82, so you will differ, but your imaging shows that the indications for intervention stands, because this ostial location is really confusing.
yeah.
So
So again,
if at least
again,
my feeling is that is either of one is positive, then I think in
yeah.
such
So
location it should be
yeah,
done.
but either of one, but there is a trial of treating the vulnerable plaque, but we
Yeah.
have not conclusive good result with the stent. As in my first slide, if we replace the atherosclerosis with the stent disease, the atherosclerosis carries the less mass than the stenting. So till date, the last decade, when 2010 to 2015, the vulnerable plaque, vulnerable patient, all these concept has been prioritized. But there is failed data to shows the treat the vulnerable plaque. If we give the high statin and guideline directed medical therapy, the vulnerable plaque turned to be the stable plaque. They have shown. So stenting is not the answer. So on even the as per the evidence till date, I still believe, though I am given the topic of imaging, if patient shows the high risk of imaging, but if I have to treat, then I have to off the table indication for the revascular. Your FFR is negative, morphology shows the high vulnerability. That's why I am taking the decision of stenting. That
Yeah.
off-label indication I am approaching that I have
Now,
to discuss with
is there any data that you see? We know that FFR is also negative in a critical
Ah.
lesion, like say 20%
Yeah.
or 25%.
Yeah,
How
yeah.
much of these patients will be having an ostial LAD location? Is there any such data? Dr. Sanjeev can
yeah,
No,
give
yes,
some.
I don't think
Yeah.
they have characterized the lesion into ostial or mediality, or that particular data has
How
not
much
been
is
given
the
in any of the.
policy of the
But I
FFR
think
in ostial location?
FFR applies to all these except left main lesions. All these trials actually included non-left main lesions, and non-left main lesion will include a ostial LAD lesion also. So I suppose that ostial LAD lesion must have been included in all these trials, and we need to take this data very seriously. And if FFR is negative, definitely in this case, I would like to keep this patient on medical management.
yeah.
I think FAME 3, I'm sorry, in FAME 3 data, we have clearly known that even if you guide your PCIs and leave lesions, which you felt were FFR negative, were actually not going to yield you CV outcome superiority, especially when you're looking in terms of CABG outcomes. So that probably you can extrapolate and look at in terms of that FFR might be good in this patient to leave, not to stent. But we don't know when you're looking at it in terms of medical management, fine. But what about if this patient was to have a multivessel disease and you were guiding FFR as a revas strategy for a multivessel disease strategy? You're stenting one and leaving the other. That way, probably it's not going to be a good idea based on FFR FAME 3.
True.
Yeah.
The second thing is that we can do many tests like troponin, etc., to demonstrate whether this patient had acute coronary syndrome or not, and then we can take the decision based on that also. If patient has got troponin negative and symptoms are atypical, then definitely FFR. If FFR negative is patient has got FFR value of more than 0.8, then we can manage this patient medically.
But
So I think everything has to
even in the ACS category, the FFR negative lesion carries the worst outcome than stable angina. That is the data source. So ACS category is a different ball game, and stable angina
Definitely,
category.
definitely.
Yeah, I think good, excellent presentation by the presenters. My question I would like to ask Dr. Shukla. Actually, sir, what are your insights on this hybrid coronary imaging that the new data is coming in?
So OFR and all these things, we have to combine both. It is analyze the elephant as a whole. We cannot see elephant as a trunk or any elephant as a column or any. We have to analyze as a whole. What we are treating. We are treating patient as a whole, not the lesion. So we have to understand ourselves, and we have to supplement our understanding with the evidence base. So Dr. Kamalesh asked ostial LAD. We take the scenario, tricky scenario that FFR is negative, ostial LAD. and shows the vulnerability, thin fibrous caps and 67, then even evidence-wise, it will be difficult to leave the patient. Then we have to discuss it out with the patient. The morphology you carry the some risk factor. It is like though the till date evidence shows the medical guided medical therapy will reduce your risk, but it's not guaranteed.
But recently there is a publication that even FFR guided intermediate lesions which you have left also carries a future event rate. It's not always that they will not get the events. So both way we have now evidence. So ultimately, you will have to go with the patient and both the modalities, imaging finding, and plus the, as Dr. Sanjeev has said about the other cardiac enzymes and other things, and then take a call.
Yeah, one more point I would like to add is that recently, because British guidelines, they say that they use CT angiography as a class 1 diagnostic modality in the patients who are present with the chest pain. So they have actually now included the CT guided FFR in the angiography also. So that has again actually that had reduced the chances of patient being referred for the invasive coronary angiogram and the stenting. So we can that kind of scenario can also come in the future when we actually incorporate the CT FFR into all the CT imaging, and then we can decide whether patient will require an invasive angiogram or not.
And
Dr. Sidana, only challenge with the CT FFR and the CT angios and FFR, it puts a lot of huge radiation burden on the patient. That is, always if you are in somewhere dilemma, then again you have to put patient on radiation.
Definitely, that's true. Contrast and radiation is very important.
Dr. Anand Ahuja question, FFR negative, morphology positive. Still, scientifically, we have to leave the lesion, but if you have to discuss it out openly with the patient regarding the morphology, it is an off-label indication for reversal. Similarly, so we have to take as a whole analytic, whether where it is situated, ulceration is there, and FFR, that was I believe.
Absolutely, and also the patient. I mean, whether the patient profile is of ACS, non-ACS, stable, atypical angina. Any other comments from the panel? Else we had a wonderful session. We can move to the next session. Yes, Jael. Yes, Jael.
Just for the sake of new fellows and recently passed out cardiologists, I would like to ask Dr. Shukla, what are the difficulties and disadvantages of OCT, especially in LM interventions and other disease subtypes, or in relation to different like anatomic subsets or other lesions? So
OCT now, initially the one was a dye. RCA we can do without dye also. Normal saline injection we can well do the OCT. So the dye contraindication of OCT is ruled out in the RCA. In lab system still we require the dye. Second is the larger the diameter, then the OCT it is reconstructed image. The larger the diameter, then the left main it's difficult, particularly to ostial left main. One cannot assess by the OCT. Third is OCT and the actual coronary diameter are matching much more. If you analysis the diameter coronary diameter, I was there slightly overestimate. But OCT and the actual, they have in the analysis, they are much more one-to-one comparison with the OCT. There are more thin fibrous cap, more defined with the OCT, H dissection or more defined with OCT. The learning with the OCT with the less, I was with the more. That was what are the salient difference I like to highlight. Any element you can point it out?
I think that session we had, Dr. Jael's question was very pertinent. That session we already had for IVUS versus OCT. That was a separate debate that already was there. We wanted to pitch imaging versus FFR, but a very valid question because some of those might have missed yesterday's session on IVUS versus OCT. Dr. Utsa was saying something. We can have your closing comments. Yes.
Yes, sir. I would also like to ask, in case of one scenario, what if there is a bifurcation lesion and there is a stable plaque in the LED, suppose, and the diagonal is having a a vulnerable plaque with a significant FFR lesion? What would you do in that case?
Yeah, I think for diagonal only, I would not like to treat this patient with the stenting. I would like to keep this patient on medical management.
No, Dr. Sanjeev, but if your diagonal is 2.5, then patient is symptomatic.
So if it is ostial, you want to make us more tricky wicked, both of us.
We had another debate on that, on a small vessel disease, where we debated DEB versus DES. So
we both
you can go back to that session also.
Yeah. So
if
only
patient is symptomatic, then
Yeah.
we need not to do FFR. Then definitely without FFR
So-
we can proceed with the PCI.
the conclusion remark is the stent is a iatrogenic disease. Native atherosclerosis is the still better. So choose the stenting in the properly indicated. Limit the metal as small as possible.
Yeah, as Danton Cooley said, replacing valve with another valve is replacing one disease with another. I think we should be framing that replacing a
very
plaque
true.
stable with an unstable plaque by a stent is also a dangerous thing. So we should all be knowing when not to stent before we know what to stent.
Yeah. Okay.
True.
Very well.
Thank you.
Thank you very much.
Thank you.